let's get started. If stragglers come in, we'll direct them up to these couple chairs up here. Thanks everybody for coming. I feel really lucky today to have two people from the Ag Workers Health and Services, which is, I've learned a lot about the services they offer, and they're pretty great. So I'm excited that they're here to be able to tell us more about it. We've got Vicki and Nieves, who are here to lead this on working with interpreters and telling us more about what they do.
Thank you.
So thank you for having us, because we love talking about what we do and where we work. And she had just said we're a hidden gem. We'd like to be a less hidden gem. So we're hoping you'll help us with that. Our overall name, our business name of our organization is Montana Migrant and Seasonal Farm Workers Council. And it was founded in Montana in the early 1970s. And the story goes, and it's not a story, it's the truth. A woman named Maria Stevens, who came up from Mexico, had a friend who was a registered nurse, and they'd heard that there were some harvesters at Flathead that come to harvest the cherries. And they heard they were migrant workers, and they thought, I wonder if they could use some health services. So they took an old pickup and a nurse's bag and filled it with a bunch of supplies and went up there and took blood pressures and did some minor urgent care kind of things. And the workers really appreciated it. And then when they came back, they found out there were a lot of migrant workers in Montana doing agricultural work, and that's when they decided to apply and got their first HRSA grant and opened Montana Migrant Council. So it was opened in the early 1970s. Our administrative office and first clinic was in Billings, and then a few years later we opened a clinic in Fairview, which is really far east Montana. When you drive in Fairview, on one side you're in Montana, but on the very other end of town, you're in North Dakota. So they say you can see North Dakota from standing inside of Fairview. So that was our second clinic. And the agricultural workers up there are the sugar beet harvesters, and still are. There's a lot of sugar beets, but it's also one of the largest honeybee area in that part of our state. Montana is the second leading honeybee and honey business in the United States, which I didn't know. Recently we were first. I don't know who took over, but we were first, which was a surprise to me. I didn't even really realize we had that many bees. And then we opened a clinic in Dillon, and that clinic opened because a family nurse practitioner student did her thesis on migrant workers getting their primary care at emergency rooms, which is not a great place to get primary care. And she realized that there were a lot of migrant workers in that area as well. And her thesis was brought to our administrative office in Billings to our awareness, and then it became very apparent that Dillon also had a lot of migrant workers. So we opened our third clinic there. And then it'll be 5 years, I believe, in November this year that we opened a clinic in Lolo, because that's a big area for migrant workers. One of the groups that we service are called H-2A workers, and a lot of Americans don't know about this program. It was started many, many years ago. I think it was in the 70s as well, where if agricultural workers or people who own land or property, or we call them growers, the people who are the ranchers or the farmers, or they could own a nursery. If they can't find people from America to work for them, they're able to go to another country and bring a foreign worker on what's called an H-2A work visa. And they can usually come up for a period of time, which is, it has to be less than a year. Our workers mostly come up on a 9 to 10 year H-2A contract. And we have people who come from Peru on an H-2A contract, and theirs is 3 years. So there's a little bit of difference, and I don't really know why. The people from Peru can come up on a longer visa. But that was started in America years and years ago, and I never hear about it when elections come up or they're talking about migration or migrant workers. I've never heard that come up about all the people we have asked to come here for many, many years to do work that Americans won't. So we heard that there was a large group of H-2A workers coming up in the Bitterroot area, and so we opened a clinic in Lolo to address that. And then 2 years ago, the agency that was running the migrant clinic out of Powell, Wyoming didn't want to do it any longer, so we put a bid in for that grant and got it. So that was our 5th clinic. So I'm the clinical director, and I'm a family nurse practitioner, women's health nurse practitioner, and I'm responsible for all the clinical staff in our clinics. We've been nurse managed since we started, which is kind of a fun concept. We have always had a nurse who's the clinical director. We hire nurse practitioners as our providers. And we also have dental hygienists and behavioral health counselors, which Nieves is our behavioral health coordinator. And we practice what's called integrated primary care, which means that if we as nurse practitioners are seeing a patient and we feel like they benefit from the behavioral health counselor, we'll bring that person right into the exam room, right at the time we're saying, gee, I have someone else in the clinic that I think could really help you. I'd like to bring them in so you can meet them. And we'll go get the dental hygienist or the behavioral health counselor right then, interrupt them with whatever they're doing so they can meet the patient and do what's called a warm handoff. And that just is a gentle way of introducing someone else to your clinic and hopefully they'll kind of connect, and sometimes they'll have an appointment right then, maybe even as part of my visit with the patient or right after, or schedule an appointment very quickly. Research has shown these warm handoffs have really helped with people coming back for appointments rather than not knowing who they're coming to see. They think that meeting that person one-on-one really helps. So we see a lot of H2A workers. There's also something called H2B workers, just for your information. They are people who work in business that aren't agriculturally based. So the A stands for agriculture and the B stands for business. And they're like, if you go to Big Sky, like their big hotels, I guess the basements where a lot of the work is done is almost all migrant workers. If someone who owns a business can't find American workers, then they can apply for these H2A or H2B workers and bring them here to work for them. So not in our Lolo office, but in our other offices, the majority of our patients are H2A workers, and in a lot of our clinics, for instance, Dillon and Powell, they have we have 80% Spanish speakers. The majority of our patients in Lolo are not Hispanic patients. We kind of have a very interesting population, and I think it's very fun. We have a lot of new farmers up here, especially organic farmers who are just learning how to be farmers, who it takes them a while to get their business going, and so one of the things they can't afford is health care. So that's the whole reason we were established, is to provide health care for the migrant and seasonal farm workers in the area. The government describes migrant as those who have to leave their home to find work. Seasonal means they don't. So seasonal would be like someone who just lives and does agriculture year round. But it got very confusing because seasonal farm workers doesn't really mean anything to anybody. They still saw us as migrant. And so about 3 years ago, we changed our name to Ag Worker Health and Services because we want to be more available to everybody. We do a lot of outreach clinics. We have 2 mobile clinics. One's medical and the other one's dental. And if people can't get into our clinic and they have a group of agricultural workers, we will go to their work site and provide medical, dental, and behavioral health services. And so we wanted to make sure that everybody knew that they were available for our services. And there's a large ranch that we often go to up out of Polson, and it's a huge ranch. Oh my God, I can hardly believe how big it is, because every time we go to another place, and I'm like, this is still on this guy's ranch. It's so huge. It's a huge Angus ranch up there. And he has a lot of migrant workers, H2A workers, and we were doing a clinic one day, and this big truckload of Caucasian Americans came by, and we're kind of laughing, and they said, look, you can get health care if you're a migrant, but if you're a Caucasian, you can't. And we were like, oh no, you can come in too, but because our sign said migrant, they just even wouldn't come in. So we want to make sure that everybody understands if they work in agriculture, it doesn't have to be their only source of income. It doesn't even have to be their primary source of income. Anything they do allows them to have services from us. We are in the same ball of funding as the community health centers, just like Partnership. We're also considered a federally qualified health center. And so we're just like Partnership, but we have a narrow base of people that we can offer services to. They have to do something in agriculture to obtain services from us. We offer primary care, birth through death, including prenatal care, which we all think is really fun to have prenatal patients. Our patients come in to see us, they register, and their services are based on sliding scale, how much we ask for the services, just like Partnership. The difference is that they don't have to pay. If they cannot afford it, they can still access services from us. We're not free, but the majority of our patients' income is way below the poverty level. Many of our families make like $7,000 a year. They've got 4 children. I don't even know how they exist at all. But so they come in and we have a very small base service fee, but if they can't even pay that small service fee, they'll still get the services that we can offer. And then if they're on a certain sliding fee scale under the poverty level, we issue vouchers to help them pay for x-rays, mammograms, maybe a cardiology referral or something that we don't do within our 4 walls. So we provide medical, behavioral health, and dental on a regular basis. The other thing that we're a little bit unique compared to other community health centers is our outreach services. We have staff that we hire as outreach workers. A lot of them also speak Spanish and are interpreters as well. But they go out into the areas where there should be farmers and ranchers and farm workers and tell them about our services, help them understand our services, and they'll register them to see if they qualify. And then they also do things like we provide transportation from their site to our clinic, or they'll provide services like driving them from their house to a consultative appointment. They also do interpretation in our offices. So they do all the social determinant kind of things that sometimes occur before the patient even walks in the door. They make sure that they've got housing and food and clothing and hook them up with all the services in the communities. So sometimes the people only see the outreach workers and they might not even get into the clinic at all, but the outreach workers are making sure that they have food and housing and are safe, and help them access the services in our communities that they may need other than the dental or the medical, dental, and behavioral health. That's a lot. So we changed our name to Egg Worker Health and Services 2 years ago. We are also recognized as a patient-centered medical home. You may have heard about that. It's called PCMH. The government, HRSA, when they allow, or I say allow, you to operate one of their grants, wants everybody, all the clinics that receive HRSA money, to be patient-centered medical homes. So we went through the accreditation application process, and we are accredited at the level 2. There's a level 3 that we're striving for in 2 years. But it's a whole set of standards we have to follow. For example, one of them are that we offer extended services. Not everybody can get into a clinic Monday through Friday, 8 to 5. And so we are required to offer extended services. So one of the things we do are our outreach clinics that we go to the sites, but we also have evening and Saturday morning clinics. They have just a whole, it's a big, huge application process, but all the community health centers have had to go through that and have attained some recognition as a patient-centered medical home. I did mention we're HRSA funded and HRSA accredited. They do site visits, if you're familiar with CHAMPS or Joint Commission accreditations. It's the same kind of thing. They send a team to your clinic. They have a big book of standards they want to make sure that you're meeting. And then twice a year we have to report to them. It's called UDS, Uniform Data System measures that we have to show through our data collection, through our electronic health record, that we're meeting the clinical measures that they expect us to meet to continue to get the grant. And so we just went through this. Every 3 years we have what's called a competitive grant, and that means that someone could come along and say, I want that grant, so I'm going to apply for it and get it. So every 3 years we have a more in-depth grant writing procedure. And so I just brought this to share with you because I think it's interesting, and I didn't understand. So every community health center that receives money from HRSA, I wrote, this is our HRSA grant report that we submitted in August, and these are the clinical measures that all community health centers have to meet. And I'm not going to go through all of it, but I thought I'd just explain it a little bit. The clinical measures are the ones on the left. This is what HRSA expects us, and we have to prove that we're meeting twice a year. And then the second one was the goals we reached in 2018 compared to what we reached in 2017. The next column is our goals for this measure. And if it says HP 2020, that's Healthy People 2020's goal for that measure. And one of them, under colon cancer screening, we actually exceeded the 2020 goal. With that one, we already met 75%. And the fourth column there of the data is the Montana Community Health Center's average. So I thought I'd just share this with you. This is what we submitted with our August competitive grant report. And these are the measures that we have to show HRSA that we're meeting twice a year, as well as when they come to do their site visits. So when you refer patients to community health center, you can feel very, very comfortable and confident that they are getting very good care, because this is based on national clinical guidelines, and this is the care we should all be getting from anyone that we receive services for. But you can feel very confident that people that seek care from community health centers are, or they wouldn't be receiving grant money from HRSA, which they all are. So just interesting information I thought I'd share with you. Any questions about our organization? I gave you each a brochure. I didn't know if you wanted to keep that or if that was something you could gather back up and give people that might come in that are looking for a primary health care provider. You could refer them to our Lolo clinic. Like I said, we do outreach clinics, so if there's a group of people, we will go to Finley Point. Oh, yes. Our biggest outreach clinic is at Finley Point. We still go to Flathead every year, have been since the early 70s. It's the weirdest thing to have a job that's based on a crop. We don't know when we're going till the cherries are ready to harvest. It can be like 4 days, and the Cherry Growers Association calls and says, they're ready to pick, you better come. And so we have this whole group of people that we organize with this. They say, well, when do you go? And we're like, I don't know. I'll tell you when the cherries are ready. And it really always puts people off, like, what do you mean by that? But we have to wait. And we've got a cabin across from Finley Point Grill. We've got a 2-story cabin that the community, there's a community group there that raises money for different scholarships and things like that in the Polson area that they're letting us use for the 3-week cherry harvest. And so we go up there and we do all the care. We do all dental. We have a dental 2-chair dental motor home, and then we set up the upstairs of this big open clinic. We spend a whole day turning it into 4 exam rooms and 3 nursing stations and a waiting room and a lab. And this year we saw 600 people in the 3 weeks we were up there. So it's like big outreach, busy, fun. The people are all H2A workers that come there, and they come from all over. We had some from Hawaii this year that was so interesting. I had never had someone from Hawaii there. He flew over there to do the cherry harvest, because the people who work for H2A or migrant workers call what they call a migrant stream, and ours come from the western stream, and they usually start in Mexico and come up in California and do the avocados, and then go into Washington, and they do the cherry harvest there. They have an early cherry harvest, but to compete with Flatheads, now they do a late cherry harvest. So then their cherries are all in the markets, and it makes less places for our cherries to go. So that's commerce, but I'm always like, that doesn't seem very fair. But then they come over here and do our cherry harvest. Then they often go back and do the apples and go back down into California, back to Mexico. So that's how they follow the crops. So it was interesting to have them from Hawaii, because I don't know what stream. I suppose they're western, but the families that came from there harvest pineapples and coconuts, and so it's always fun to see what everybody does. And so we still go there every year, and we are going back to cherry. There's a cherry juicing plant, a new one up out of Finley Point. We're going to Friday. And it's a couple that for 7 years have tried to make this cherry juicing business, and they haven't been able to have health care for themselves or their employees until they get their business off the ground. So we're going to go up there, and Wednesday we're going to Manhattan. There's a large group of dairy farmers in Manhattan, so we'll go there. Our dental motorhome comes from Billings, and we have the medical, and we go there and meet and see all the patients for a day. Any other questions or comments? Okay.
A lot of information.
That's a lot of information. So Nieves, yes.
Do you have sometimes the same families coming back year after year after year? You get to know them?
It is. It's actually really fun. I've been working in our Dillon clinic since, like, I'm going to say early 1990s. And so, yes, now, I hate to say this because it makes me feel way older than I probably am, but I'm seeing the ones that were the toddlers getting vaccines from me now, bringing their kids in, and they're living with their grandparents, and and the great-grandparents are coming from Mexico to visit, and they all come to the clinic at the same time. And I've been going up to Flathead since '93, and the same families come back. And so it's really fun to see them and see their families grow. And yeah, they still come back. Some of them laugh. They say, I don't even need to pick the cherries. I come for a week by the lake to get my tooth pulled and my pap smear. So, I mean, so it's really fun to meet them and understand what they do. And there's a group of women who came up there that are just so dynamic. It just is so amazing to me. I just I look forward to seeing them every year. But they came up one year and were driving around Flathead and saw an orchard, organic orchard that really needed help. And so they went in there and said, if you give me a place to live or give us a place to live, we will take care of your orchard. We can help you make this orchard more productive. And so they did. And then the man was so appreciative, he took a little house and let her brother come in and remodel it for them. So they come up for the month and work on only this organic farm of cherries, and his production is just like, I don't know, tripled or quadrupled or something from the work they knew how to trim the plants, how to water them, how to do what needed to be done to take this old orchard and refurbish it. And they have this really cute little yellow house, and they plant flowers in front of it when they come. And so, yeah, it's very fun to see them over and over. Yes.
So are there clinics along the way for these people, you say, in California and Washington?
There are community health centers that are agricultural funded across the United States. We have a little booklet that tells you all the places that they can go. So yes, there are clinics that we can hook them up with.
And say they're in California and they have a medical need 2 months from now, do they refer them then to you?
They will. We do a lot of follow-up with the people that we see at Flathead. We work on that till the next year we go back. We do a lot of PPD screening and get quite a few tuberculin, converters and are positive. And so we'll try to follow them through their health departments to make sure that they get on the INH prophylaxis. And there's also an organization in the United States called Migrant Clinicians Network that's kind of a worldwide migrant agency, and they will also follow people. So if we have someone we're really concerned with, we'll hook them up with MCN, and they will track them clear back to Mexico or any of the countries they came with to make sure that the care that we're worried about will continue after they leave. We had some really brittle diabetics this year. Of course, came in 10 minutes before you're going to close, and you're like, you should be hospitalized. But so the cherries really bring out the diabetics. They start eating cherries because they're picking all of them. They come in with these blood sugars of 600, and you're like, oh my God. But the cherries are not good for diabetics. Yes.
So with all the immigration issues, have you seen any reduction in people seeking services because they're afraid they're going to be connected?
Unfortunately, yes. Not a lot, but I think that they figure out where they can go and where they can't go.
If they have this designation, that's a legal way to get in, right? So,
right.
But there are some family members that are not sure.
Oh, yes. Some family members do come up not as an H-2A, and they're not in the country legally. And we don't have to ask those questions, which is really good. We're just there to provide health care. We really don't know if they're legal or they're not. We really don't. We ask if they're H-2A just for our data collection, but the only times we really need to know is if we need to seek services for them that require documents. So we don't ask until we need to. Like if they need surgery, that becomes a problem sometimes. Or if they need medication from one of the medication assistance programs, then we need to know. We don't want to put them in harm's way of maybe getting, recognized as not here in the country legally. We're considered kind of like a sanctuary. It's safe for them to come to the clinics. The ICE and INS cannot come into our clinics while the patient's seeking care, but it doesn't mean they can't once they leave the grounds of the clinic or the mobile clinic. We have seen a decrease and have had people talk about being scared to travel. And so in MCN, the agency that I mentioned, they came up with a lot of ways to help people get their care. Like if they're leaving here to go back to Mexico, how are they going to get their medications along the way? You don't want the person's undocumented to go in and pick up a prescription, so you help them learn who in the family should go in to do that for you, and try to get them to get all their records before they leave, so they're not having to worry about transferring care somewhere else. But Nieves can probably talk a little bit more about that. She's been working with an attorney on immigration issues, but unfortunately, yes,
And I
it
didn't
is.
really I didn't bring anything related to that or to mental health, which is my part, one of them.
We wear lots of hats.
But yeah, with that group of patients, for instance, we try and focus on creating a safety plan, like the things that they need to know in order to keep them family safe. Because things can happen. We are like a sanctuary, yes, but once they're out, they're out. And the risks are out there. So, making them sure that they know that they have what they need to know in order to prevent them family from suffering from something that, due to ignorance, they could have prevented. So those are things that we work together. It's just creating awareness of what is needed in these situations.
But it's hard for all of us to see families that have been here a long time affected by this. It's very sad to see them, one member of the family deported and the rest can't leave, and so it's interesting. But the most interesting thing to me is how you don't hear that we're funded to take care of these people. I've never heard that. I always listen when we're having new elections or discussions about immigration, that there's a whole health system in the United States set up to take care of them. So, all right.
Is it a jeopardy of food being lost, or is it?
Well, we
Since
wondered.
haven't heard it discussed
Yeah,
about dropping it.
no. We thought in MCN, the organization I was talking about, they did lose a lot of their funding, but they had other funding so they can exist. So we always wonder if it's going to happen, but apparently it takes quite a while to move legislation like that, and it would take like a year and a half or so for it to trickle down to affect us, but just hopefully it won't.
Well, our thought is that like the hospitals behind keeping these programs too, so they don't end up with more people in their ERs, I'm assuming.
Not really.
Really, they aren't. Darn.
I don't think that a lot of people know we exist. I mean, we've been in the United States for a really long time across the country, and we've been in Montana since the early 1970s. Most people have never heard that we even exist.
I don't know you guys, but I do hear people asking me, so are there a lot of farmers here in Montana? I'm like, really?
It's like our number one employment.
And of course, I'm not from here, and I'm getting that question. And I'm like, really?
That's really surprising.
Yeah.
But it's really fun in some of the communities like Dillon. Sometimes their gas stations have their ads in Spanish, and they have 4 great Mexican restaurants there that were all our patients at one time.
Because I think it's good for you guys to know that the Department of Labor, they have this percentage of the H-2A, which are the visa holder for just agriculture. I think it's 70% of the agricultural workers that come from another country are based in Madison and Beaverhead County. So of course, there's a huge Hispanic community in that area, and they're very, very sensitive towards them. So yeah, 4 restaurants and everything in English and Spanish.
Yeah, it's
So,
really fun. That's an interesting area because the Beaverhead area, most of those ranchers don't live in Montana. They're owned by foreign companies, and so they're pretty much managed by H-2A
Yes.
families because those ranches are so huge. All right, I will turn it over to Nieves.
Okay. And I don't know if we're supposed to turn this on, like we have it just.
I think it's okay.
Okay.
He's monitoring us.
Yeah. So I am Nieves Gonzalez, and I am the mental health counselor and coordinator at our agency. I am based here in Lolo, but I travel to Dillon as well, and to Billings, and I haven't been to Fairview, thank God.
She's
Or-
saying that 'cause it's 12 hours.
Yeah.
Next door to that clinic store.
Or to Powell. I am licensed as well in Wyoming because since we have that agent, that the clinic there, we need to comply with what is required. And if to talk a little bit more about mental health, so we have introduced what is the telephonic or the video conference services, so that I can see those patients that are in Fairview, because some of them they decline the interpreter services, and so they prefer to have someone that is bilingual and that understand that, which is the part that I'm going to be talking about interpreting. I am not only an LCPC, I am as well a certified medical interpreter. I think I'm the only Hispanic clinician in our organization. So not only the language, but to the culture, which is something that we need to understand too, that affects the outcome of, the health outcomes of our patients. So it's really cool for me to work in a place where I have the opportunity to speak Spanish, knowing that, there's a super huge prevalence of people that speak English and not not much of Spanish. So it is good for me to be there and serve this population. I would have to say I might have some issues here, when reading, so I ask for forgiveness. Entering, I just told Vicky this morning that I needed to send records for someone that I refer. I'm like, it's so embarrassing because now that I'm reading them, I am finding all the mistakes that I made. So please don't mind the issues. So interpreter services, and this is something that I really enjoy because I enjoy and suffer too, because there's a lot of issues that can come with not interpreting correctly. And of course, I am the mental health counselor, and I have not had the need to have someone being in there, being the triad, the third person in the session. So I guess that I have not, until very recent, put myself in their shoes and see how does this feel and how does that work in a visit, especially with mental health counselor. I'm not gonna be focusing in mental health. I'm gonna be just focusing on what is having a medical interpreter. But until then, I realized we need to do something better. We need to strive for something more than what we have. And we have been doing an amazing job, and we have amazing personnel that work with us, but there's always something else that we can do. Okay, so the need, just to put us like in a reference. So 25 million person in the US are limited English proficiency, and we call them LEP. That's the way that you're gonna be finding these anywhere you would ask for when there are interpreter services or translation. Limited English proficiency is how we define this population, and it doesn't matter what the language is. They're just limited in English. LEP individuals face many barriers to critical health and social services. Language barriers often result in an ability to access programs, unsatisfactory encounters, and possible negative personal or healthcare outcomes. Oh.
Yeah, that one is a funny one. Sometimes you need to use the arrows.
Yeah. So where are the arrows? Oh, here.
Yeah.
Okay. This is a very interesting case that happened in 1984, and I guess that this is the one that I presented to the administration. We have to be careful with how we interpret and the people that we use, because there are a lot of tricky words, and we can make a $71 million mistake. So this was a case that happened in Florida, and intoxicated in Spanish, we have that word, intoxicado, but normally it is related when you have eaten something and has been causing you whatever.
Nausea.
Yes, thank you. So this guy, his name is Willie Ramirez, from a Cuban heritage, living in Miami. So he ate something that caused him to be intoxicado in Spanish. So back then, when the family called 911 and the ambulance came, it was a family who led him, the family or someone someone that came with the ambulance. That, of course, thinking in Miami, everybody is bilingual. Well, most of them are bilingual. It's not generalized. And when the family explained what had happened to him, that he had been intoxicado, oh, it's easy. He's intoxicated. So immediately, okay, so he's drunk. Let's wait. Let's sit and wait until he's it gets over. And they waited and waited, and this guy had a brain hemorrhage, causing him to be quadriplegic. So the family filed a complaint, they sued the hospital, and they received $71 million for that. Yet, he is quadriplegic. Doesn't matter how much money the family got. So for one for one mistake of one word, the life of someone can be in serious danger. So that is just one of the many examples that we can put as when we're using people that are not necessarily qualified for interpreting. So according to the Title VI of the Civil Rights Act in 1964, every organization that receives any type of federal funding, it's obligated to provide health care to anyone, or not to deny services to anyone based on their race, color, or nation of origins. So know these, we all follow the Title VI of the Civil Rights. So we all are obligated to provide, all the ones that receive, of course, federal fundings, are obligated to provide health care to anyone and do not discriminate them on the base of the race, the benefit, none of that. So, what is different when we use an interpreter? Knowing these, we do provide services to people that require an interpreter in the session. We follow the Title VI, and what it is like. And Vicky, she has been using, and she knows Spanish, but she has been using an interpreter too since the day she started working with us. So as for examples or barriers or ideas, she's the go-to person if you would like to ask her something. Yet, I can explain you a few other things. So this is what we're used to, the clinician and the patient, right? That's what in our head it is, because we have not encountered the necessity to talk to have someone else in the session, because we're having to counsel or to visit someone that doesn't speak our language. But this is actually what happens, right? When we have a limited English proficiency patient, we include a third person in that, and that brings a lot of issues. An interpreter, a medical interpreter, what do? The purpose of the interpreter is mainly just to facilitate. The interpreter is the conduit of the visit. He is the one that helps the provider communicate effectively with the patient and understand what is happening. An interpreter will help eliminate different types of barriers between the patient and the clinician. And of course, we're just talking about language, which is the linguistic one. But we also encounter in these in the sessions that you would have not only the linguistic barriers, which is why you're having initially the interpreter there, but you would have the necessity to work on the register barrier, which is the complexity of the words that are being used. It doesn't matter if you're speaking another language. Medical professionals speak weird, don't they? So like they have these terminologies that we don't get, even if we are educated. So the barrier of the register, it's one that we work as well, as an interpreter. The other thing that, just thinking, because I will go back and forward, of all the things that the medical providers, the terminology that they use is all these acronyms. So just talking to Vicky earlier this morning, and I have been in this field for a while, and I have been with her. I'm like, what is that? Please, like, what all these means? Because it's so easy to them just to say, oh, I don't know, whatever the letters are, and assume that we understand. We don't. So. The other one, and it's a cultural, because there is a cultural barrier. We have to understand where that person is coming from and what their beliefs are in order for us to understand if their health outcome is going to be dependent on these. To help understand and explain the providers what this means, so that they can be a little more sensitive. And the systemic, in order to understand, help understand the patient as well. That this is a culture within the medical environment, and you might not only need to have a herbal tea. You will need this other medication, and explain all that so that we all achieve our goal, which is to provide a great health care. Who can serve as an interpreter? Trained bilingual staff, staff interpreter, which is what we have. We have people in our sites, employees of the organization with a specific interpreter duties. An interpreter could be someone that you contract, that is a freelance interpreter. A non-employee, contractors paid by, when you're having that consultation, that visit. And you can have remote interpreters, which are the ones that you do via phone or video system. The least preferred options for interpreting, and this is what has been happening for a long, long, long time, that we have been using family or friends. We have been using minor children's, untrained volunteers, and patients waiting outside. Yeah, and we say this, and I know there will be many, many, many clinics that have said, we have done this, because it is. And I think it's important to understand that being bilingual does not mean that you are, I'm gonna say, equipped to be an interpreter. And this is why. Using family, friends, minor children, volunteers, strangers, and other patients exposes the agency to liability under the Title VI and ACA. And ACA says basically that whenever you, ACA 1557, what it says is that it describes what type of interpreters you have to have. It explains that you have to have interpreters that are trained in order to provide better service. It may result in a breach of confidentiality because people don't understand. If you don't train someone, they don't understand what HIPAA is. It may result in the patient being reluctant to fully disclose critical information, and we might have this, for instance, in small communities like in Dillon, where there are people that have been there for a long, long time. They might refuse, I know this person, so I'm not gonna go and use this interpreter. I'd rather have someone from another of our clinic sites to be the interpreter because they might feel exposed. It might result in additions, omissions, and changes in context of communication. And this is when people don't understand that they have to interpret word by word and the meaning, and they just do a summary of what the visit says, and there's a mistake. It may destroy the power base within the family, especially when we're using minors. What are the roles that we are putting the kid to be suddenly there? Oh, so I have the power over my parents because I know what the provider says here. So this is why we don't do it. When we're using an interpreter in a patient visit, it's very necessary, and we do that in our agency. We provide enough time so that the visit flows adequately, because you will need more time. The interpreter sits beside the patient in a 45-degree angle to the patient. And for instance, the patient faces the provider, and right next to them is the interpreter, but the communication needs to be with the provider. You don't have to be, the patient doesn't need to be addressing the interpreter, neither does the provider. If using a telephone interpreting services, the visit, you can do the visit in a private room, of course, because we need to encourage privacy and confidentiality with a speakerphone or a second handset. It's necessary to use short sentences because we all have our issues of memory, don't we? So, let's be short so that we can deliver the information the best way we can so that it's right, and we don't summarize because we don't want to make mistakes. And expect the interpreter to interpret everything. It's important within the visit that the interpreter knows that they need to be transparent. What I'm telling to you, the provider needs to know what I told you, and the patient as well needs to know what I told the provider, so that there's no one there wondering what is being said. As patient for clarification, and this will happen from the interpreter side and from the provider too, because we need to make sure that they have understood what has happened and what's the treatment. The provider has control over the session, although it's good to know that, yes, the interpreter has a lot of control, because the interpreter can damage the visit or not. They can decide that. They can decide what is there, because if you don't understand what is happening, they could say many things. Yet, the provider has control over the session. A pre-session and a post-session is encouraged, and the pre-session mainly is to present the patient. Let's say that we don't have that necessarily in our agency because we have staff. We don't have to introduce the interpreter every time a patient comes because they already know the interpreter. But if you're hiring someone, a freelance that is coming to your agency, to your services, it's good that the interpreter introduces to the patient, and they explain what's going to happen and how it's going to be happening. Like what I explained earlier, that you address the provider, the patient addressed the provider, you're looking at the provider, the interpreter is sitting these, and how the communication is going to be going, which I'm going to say later here. Interpret exactly what I say and what the patient says. There are times, like, I am not going to interpret word by word few things, like intoxicated in Spanish is not the same. So there I need to explain the meaning. There are times that, depending on the culture, it's difficult to explain what one thing is, and we might have to use a different type of explanation, like a picture word, where you can explain, I don't know, how the uterus look, but there is not a word in that language, so you can explain, okay, like a ball, or... The interpreter is not supposed to add anything. It's not supposed to omit anything. If there's anything that they don't understand, it's important to know what I was saying earlier about the register. What the provider is saying, it's important to ask for clarification, because otherwise they're not going to be able to explain what it is. And let's not pretend that we do understand what they're saying. Don't say he says, she says. It's recommended in the interpretation that the interpreter uses first person, so that there is, to avoid confusion, and that they are sitting unobtrusively, not interrupting the flow, how it needs to go. One thing that is very important in interpreting is being aware of the nonverbal communication, because at the end of the day, 90% of our communication is nonverbal. So it's important how we address, how we sit, our face, facial expressions, our mannerism, how we deliver ourselves when we are expressing the messages. One thing that is very important, the interpreter is not only using their words to explain what the patient is saying. At times they might need to even use the gestures, because they carry a lot, and that's this part of the nonverbal communication. This is one thing to keep in mind, is that what we see is not necessarily all that is happening, and we now are a little more aware of this because we know, they're putting a huge emphasis on us to be aware of all the social determinants. Like, we will be able to see and to know the age, how they're dressed, their gender, language, their behaviors, but there are lots of things that we don't see. And they vary, they change depending on the culture that the patient is coming from. So this is very important for us to keep in mind when we're using an interpreter, when we're treating someone that is, not speaking the same language as we do. We should not assume anything, because there's a lot of things that are behind. Why is it important to consider culture in a healthcare? Oh, I'm sorry, this is too little. So culture is an essential part of who we are as individuals and how we understand and interact with the world around us. Culture plays a huge role in patient compliance. Every culture has beliefs about health, disease treatment, and health care providers. People within any culture group are not homogeneous, not even us, coming from the same place, not even us coming from the same household. We have lots of differences. Language is not the only barrier when we're treating an LEP patient. And another thing to keep in mind is that the provider, the clinician, has their own culture that is completely different from the patient, and that is something to keep in mind. Culture about, we have our own as a person and we have our own as a provider. So this can become a huge barrier when we're treating someone from a different culture. What to be aware when we're treating, and this is the population we treat. We don't see another LEP client from a different country of origins that do not speak Spanish. Spanish is the only other language that we offer at this point, but that's why I put Hispanic. But we need to be aware that rapport begins since the very first moment. Hispanics were very, the way that you address things, our smile, like our nonverbal communication is very important when treating a Hispanic patient. So rapport begins through exchange of pleasantries or chit-chat before beginning the business of medical history taking and physical examination. Personalismo, which is, personalizing, is an essential quality for providers to have when caring for this population. Hispanics expect healthcare personnel to be warm and personal and express strong need to be treated with dignity. Familiarity is not appreciating early relationships, and this is, especially with the interpreters. So in English, you guys might not have these difference when you're talking to someone to address respect. We use usted or tú. So the tú is it's a more personal, it's too familiar. So the interpreter needs to know these, that at least to begin, when you're knowing someone, you need to address them by usted, even if that person is younger than you. And then eventually that person will tell you, oh, please don't. That might change, but it's necessary to be respectful. The role of the family, the family is huge in Hispanics communities. The valuing of family considerations over individual community needs is strong, almost universal value in the Hispanic community. They are all involved. They all are part of someone's treatment. And depending where we come from, we might consider this too much, but this is something to be aware of within this culture. The nuclear family is the most basic and common social unit, but many extended families also are present or are within what we call the circle. It's like I can tell myself, third cousins, they are cousins. I don't call them third cousins, they're cousins. They are my first relatives. It's like there is no differentiation. We don't use that. We're a family, so we're all together. Family members provide social, emotional, and even financial support to each other. And we see these here in our organization, people that are supporting their family from here, no matter what. Oh, who knows, fourth cousin is in trouble in Mexico, so I'm sending money to them, which is one of the things that we see here. It's very common. Many patients seeking medical care will have already sought help from family resources, and that is very common. We see people that have already had their treatment because of what their family had recommended for them to do, and then they come to our services. Family involvement in healthcare is common, and healthcare providers are strongly advised to encourage such involvement and to include the family as a resource and focus of care health planning, whether for individuals or as a community. And this is very important. I'm repeating, but it is true that if, we're working with a patient that is diabetic and he needs to change his diet. His wife is very necessary there. It's something that we have to always keep in mind, wife and maybe my son, because my son is at home and I do what my son says. You know, it's easier for me to follow his direction. So we always have to be creative on how we're going to be treating this community. And then, like, what are the manifestations that we see when a Hispanic patient comes to us? And that means, ¿qué pasa cuando me siento enfermo? Like, what happens when I'm feeling sick? So physical or mental illness may be attributed to an imbalance between the person and the environment. And Vicky can tell you more about these. Because I am one of these patients. And it's very hard for people to understand what we think. But we continue to believe that because it's our source of belief, you know, it's what. Influences include emotional, spiritual, and social states, as well as physical factors such as the humoral imbalance expressed as too much hot or too much cold. We get sick because of the weather, and we manifest sickness all over the body because of the weather. Cold diseases or conditions include menstrual cramps, frío de la matriz, which is uterus, rhinitis, pneumonia, empacho, and colic. The empacho, it's involving the GI. And they will tell you that it's because it was too cold, or whatever they ate was too cold, that now is causing them to be constipated or the contrary. Heart diseases and conditions are characterized as vasodilation, and high metabolic rate. Pregnancy, hypertension, diabetes, acid indigestion, susto are examples of heart conditions. And they will explain all that to you, you know, how they went out with their hair wet and they got sick. Or there was a breeze and it was a little too cold and they didn't have a scarf on. And or the water was too cold and suddenly I have laryngitis. So, and here's, I put two tables that describe what are the beliefs and what are the definitions and how they can explain any of that. Antojo, so it's the cravings in a pregnant woman, and this is very strong belief that when you are craving something while you're pregnant, if you put your hand in the belly, the kid could come with some sort of trouble because you didn't satisfy your cravings. Ataques de nervios, which is, that's the way that having a specific mental illness they will describe. They won't say panic attacks, they won't say anxiety, they had un ataque de nervios. La caída de la mollera, which is a fontanella, may explain to occur as a result of a bump or a fall in the head. You know, there are many, many, many things that we believe, and especially this one in La Caída de la Mollera, we believe that if we put a protective amulet, you know, things like that will be helpful. That you all believe that. We're not asking you to believe it. We're just asking you to acknowledge that this is what they believe, and this will influence how they will perceive you as a provider and how they will perceive your treatment as the type of treatment that they're gonna follow in order for them to have a good health outcome. Mal de ojo, which is the evil eye, this is huge, and that's why we use, and I didn't bring it today. So in different Latin American countries, we believe that you put this red lace with a black azabache. It's like onyx. I don't know the word. Yeah, but I don't know the name of. I think it's onyx, the rock that we use. And you combine that and you put that with the kid, because those two things together are powerful enough to prevent your kid to have an evil eye, you know, prevent someone to look at your kid in a specific way that might threat their health. Nerviosismo, sickness of the nerve, pasmo, and that is related too with the with temperatures. If you're too hot, you're coming from outside, and you're too hot, and you open the fridge, well, you get a pasmo. which is a paralysis, and Vicky can explain more about that, but that's what it's believed. In susto, frightening results in soul loss. Not every Latin American country believes these. Not everyone in the culture believes that, but there are some, and so I insist it's just for us to be aware of, because you might have a client that will tell you, well, my kid is sick, somebody had an evil eye, and he's presenting, he's vomiting, and you have to understand, well, it's not that somebody looked at him in a different way, it's that your kid has one of those bacteria and it's causing him to vomit. So, but well, one thing that Robin suggested for us to present today was the remote interpreting. We do not do that because we have staff interpreters. Yet, in our sites, there are times when we might not have an interpreter in our clinic, but we use another clinic interpreter. But I did bring something for you guys to understand what it is. And there's, I guess in one of the other slides, information of where you could go to and get that. So there are different type of remote interpreting levels. The first one, for instance, level 1, sure in uncomplicated situations, it's for follow-up visits, registration, triage, appointment scheduling, pharmacy and refill, blood draw and labs. And this is, think about someone that is coming to get blood draw. And you just need someone to explain, okay, here's where you're going to be putting your arm, and this is what we're going to be doing that. You can do that over the phone and via video interpreting. Level 2, it's time sensitive. Phone and video interpreting will not compromise the care of the service provided. For instance, for deaf patients, different procedures, surgery, to sign an informed consent, medication instructions, rehab treatment sessions, social work assessment, or even a new patient visit. And you can use, in these cases, a phone and video interpreting, and an in-person too. But it's not necessarily an interpreter. It's not necessary to have a face-to-face interpreter in these type of sessions. Yet, for the level 3, you will be needing an in-person interpreting services for working with for instance, a deaf patient in a mental health situation, a patient that is confused or belligerent, when there's a conscious sedation, sexual assault, trauma, hands-on instruction, end-of-life instruction, child abuse, life-threatening situation. It's not recommended to use phone or video for these type of sessions. The challenges and advantages of using remote interpreting. So the advantage is that you are sure that you're providing patient privacy. The emphasis is on the patient-clinician, which is the end goal. The patient-clinician relationship, like there is no one there that can distract me as a patient, so I'm gonna be focusing on the provider. There's less waiting and time travel if you're using a freelance interpreter that is coming to your office, so that is not a problem. It's easier for interpreters to access resources because at times we might need to consult. What's the word for these? What does this medication is? So in order to do that, we might have the need of using a resource. So when nobody's seeing you, it's easier for you to access that. And then the other one thing is that you would have more interpreters that have knowledge of other languages, if you use the video or phone consulting. Challenges, those are less personal connection, less time for the interpreter to advocate when there's a need. Concerns about confidentiality for the patient could be, or even for you as a provider to be aware if this person is taking notes, where are those notes being, shred, or if they are. Technological difficulties, because that can happen if you don't have a wide, band for the internet. Background noise, if it is a phone, or even, the video. And the inability to not see nonverbal cues, to not be aware of the nonverbal communication. I am not gonna go through this one.
No, we
That-
actually
that
have a
w-
vendor that
okay.
we've kind of gone through some of this stuff.
So that's
to
good.
get them, yes.
Okay. And then this is what I am bringing, what I thought it was good for you to go to find an interpreter. I am not very familiar with what are the options here in Montana for freelance interpreters. I am not aware of that. I have been researching and I have not found much. I know that through the Department of DPHHS, yes, they have a guidelines of even how much you're paying and how it's worked, but I didn't see any list of them suggesting. So these are the lists for medical interpreters. I have found lists for legal interpreters, but not necessarily for medical. So I guess that we keep doing our research and see who's out there. There are plenty of people that, yes, do speak Spanish, that are qualified, not necessarily, but they're out there. These are the resources where I got most of the information for you to go to. This last place was where I got the certification myself, and they have a lot of information and resources for anyone that would like to research and get any type of documents, different languages, different ideas. And that's all. Any questions?
I was just curious, like when somebody comes in and they need an interpreter, do they have to fill out a form and say that that's okay? I mean, I'm just wondering, like with HIPAA and liability, like,
So-
or does it just happen organically?
So for instance, let's say that in your agency you're going to be seeing, and you can help me here, please. For instance, those type of forms, which are like informed consent or the Bill of Rights, those things are like vital documents that as an agency you have to have already translated. For if you're serving an LEP community, you have to have that. If you're offering the services, you have to have all that information put in place already. If you don't have that, why are you taking care of that patient? Would be the question. You know, and I might be wrong.
No, we have it as part of our consent for services
Okay,
form.
so it's all in
yeah,
that package.
right. It's just
Okay.
they sign when they come in and register. Everything we have is in English and Spanish.
But there's a lot of trust.
Yeah.
I'm just saying
Yeah.
that
Yeah.
sometimes I feel like people come in and you have to sign so many papers. and
Right.
You might get a little overwhelmed or scared or, and just be like, no.
Especially that happens more than anything when they're doing their registrations.
Okay.
Because there are specific questions. And, when we were talking earlier about immigration, that is in one of the places
Right.
where that question comes. We don't ask about their status,
Right.
but I mean, there's always that that feeling. Okay, so if I say something, am I going to be in danger?
Right, they would get scared.
So there is a lot of trust.
Yeah.
And we make sure that we explain to them that they're safe where they are with us, that they are in no
We're not a
danger.
reporting
Yeah,
agency.
yeah. So yes, there's a lot of trust. Another question?
I was interested to see the part about that you really need to, that you have a right and kind of responsibility as the person who's getting interpretation services and working with somebody else to kind of control that a little bit, because what I've heard from people here who work with phone interpretation, which is mostly, I think, refugee communities. I don't think it's so much Spanish speakers. I might be wrong though. And because I've heard people say it's like, oh yeah, sometimes they get to talking for a minute or two, and you just kind of have to wait till they're done to get going. But it doesn't sound like that's a good thing, or what
No.
they should be expecting. Do you have an idea for how to politely redirect that?
So that is actually what the provider does at the beginning, the pre-session. It's like in the pre-session you explain that. This is how we're going to be doing the session. You know, this is how I'm going to be using the services of the interpreter. This is what I'm expecting from the interpreter, and this is what I'm expecting from the patient in terms of, and this is what the patient will be receiving from my side. It's very important to have this pre-session because otherwise you're going to be having chit-chat between the interpreter, and that's not the professional type of encounter that you want to create. And it happens because the patient will talk to you. Because of course they find someone that speaks their own language, and of course they feel the need to talk and talk and talk. But for the interpreter per se, that's a liability issue. I mean, you are going to be putting yourself in a situation where you're going to be knowing too much, and you don't need to have that information.
We
So,
really found it helpful, the 45-degree angle that the interpreter sits behind the patient has been the most helpful thing that we've learned. It's pretty
Yes.
new information to have the dyad set, the triad set up that way, because they will start having side conversations, and it becomes really difficult, especially if you're giving someone a new diagnosis or something, and then the interpreter is having this chatty, fun conversation when it's not a fun visit. You know, so you got to be careful that the tone is set for the whole appointment, or you just lose so much. So just letting them know, you are my voice. You are not to be talking at all except for me. What happens sometimes is if you have to leave the room or make a phone call or something, sometimes it's better just have the interpreter step out with you, so they're not then engaging in a side conversation that you are interrupting and asking them to stop, because it's uncomfortable for everybody. But
Yes.
we found that that's the most helpful, so that you're not losing the tone of the visit.
So just so you know, I actually contacted Language Line to ask about those longer conversations, and they said they're not supposed to, their interpreters are supposed to be trained to not do that. So if it ever happens, please do give Language Line the, I think there's some kind of
Feedback?
there's something that's obvious that you can report back on an interpretation session. I forget how it works exactly, and but I'll try to look into that. And it is, and they would actually like you to say there's a lot of side conversations or something. And then I'll
Yeah,
work with that.
and that's actually what I was saying earlier, the transparency part. You don't know what they're talking. You don't know if it is medical related. You don't know if it is what you have said. So that is why it's important that the interpreter is transparent of what they're saying to the patient and what they're saying to the provider, because otherwise you're there and you don't know. Yes.
So would you go with a patient to a specialist somewhere outside of Portland?
We have, yes, if the specialist accepts us.
It's been interesting, though, over the years, a lot of them cannot use our services. So we can be a support for the patient, but not the interpreter. Because a lot of the healthcare facilities can't use someone who's not certified medically, and they have to provide their own and can only use their own. So that's been over the last few years. They've got Joint Commission. If you're Joint Commission accredited, most of those facilities cannot use an outside interpreter. But we can go as support for the family, but we can't be the interpreter for the visit.
Have you found that bigger places like St. Pat's and Community have that in place? Do they have that?
Community, some do. No, they have not said we can't, but
No.
it's been interesting.
I personally was accepted in one patient visit and to be the interpreter, and the follow-up, they told me not to come.
Yeah.
So, but this was
Lawrence
not in,
Clinic is one
yeah.
that can't use our interpreters for sure. And Barrett Memorial Hospital.
Because if they follow Joint Commission, the interpreter that they're using needs to be certified. And we have trained staff, not necessarily certified, because we can, I mean, you can have those. So I guess that it depends on, what are the regulations that each of the agencies are following.
We've had some private physicians in Bozeman say they can't use our interpreters. I don't know who's regulating them. It could be
Just worry
especially with
about
Bozeman.
liability.
Yeah,
It
yeah.
is a big.
It's a big issue.
It's a big issue.
Yeah.
Because sometimes you'll find out the person interpreting you is not saying at all what you're saying. I had that instance one time, and I know enough Spanish, I said, I don't think that's what I said. She goes, I don't know how to say what you said, so this is what I said. And I said, they're not even similar. So I'm like, that is not okay. So I just knew not to use that person again, because she didn't tell me she was having trouble with the words. She just started saying
yeah.
what she thought, and it wasn't at all.
And that happens, and we have providers that know enough Spanish to say, this doesn't sound, this is kind of shady. So yeah. No other question?
So I think this one's probably for Vicki. Do you see possibilities for ways that the health department and ag workers can work together? You know, I don't know, WIC and home visiting services and seem to be the most obvious potential.
We make lots
overlaps.
of referrals to WIC.
Mhm.
Yeah, it's a little bit interesting about WIC. Supposedly, many years ago, somebody in one of the WICs in our state reported people if they were undocumented. And man, does that get through the community. So they're very leery of WIC, all of them, but we make referrals. I hardly can get a patient from Dillon to go to WIC there.
Yeah.
So it's just interesting. I heard from a family that this is why we don't go, but yes.
Okay.
Yeah.
Well, just so you know, you've got the head of WIC and head of health
Oh,
services,
good.
which is right behind you. So if you want to chat, there they
They
are.
definitely need those services, that's for sure.
Yeah.
Yeah.
Okay.
Any questions? Thank you guys for coming. This is really great to have you here.
Thank you for having us.
That was perfect. That was exactly.